you in the room as well as those joining us online. I'm really excited to share with you the results of my study. I have a number of interesting findings in terms of looking at the prerequisites to developing a health value co-creation chain. And this really looks at the physician's role in facilitating digital health information seeking, behavior change, and improving overall health outcomes. Now, given those instructions, I'm only going to give a brief overview in terms of some of the background information to set up the study in case you need a refresher, or maybe you didn't have an opportunity to watch the proposal defense stage. Additionally, because I have 5 different models in my study, in conversations with my committee chair, we felt it would be best if I focused the limited time in discussing some of those interesting results from those last 3 models, which also embed the aspects of the first 2. So I will talk a little bit about them. So let's dive into a little bit of the background just to set the stage. First of all, my motivation for the study is really driven by 2 things. First of all, there's the increased focus among community health marketers in terms of looking at how they can improve consumers' health and wellness. And as part of this, there's been an increased shift and focus towards engaging both physicians and patients in what's known as a shared decision-making process. As part of this, it requires that consumers, and there's interest in engaging them and being more accountable for their health outcomes. At the same time, we've seen an increase in the amount of digital technology and the digital-enabled communications that are available to consumers. And these offer great potential in terms of enhancing consumers' wellness by leading to more informed decision-making. Unfortunately, the research suggests that health professionals tend to still be very skeptical, particularly of information that's shared via social media and other sources where the health provider is going to have less control over the messaging. Now, patient-centered care and patient involvement are 2 critical elements of shared decision-making, and shared decision-making has a number of benefits for both the health consumer as well as the health provider, as you can see there at the bottom of the slide, in terms of improving the quality of care, increasing the patient's self-efficacy, and leading to better health outcomes and even higher satisfaction levels. And the physician can engage consumers in shared decision-making by identifying what matters most to the patient and then recommending relevant treatment options and sharing relevant information, and really ultimately by empowering the consumer in the health decision-making process. At the same time, my research is heavily based in the service-dominant logic literature, which is representative of a paradigm shift within the marketing literature looking at how value is created. And it specifically talks about the consumer having a shared responsibility with the service provider in terms of integrating their respective skills and knowledge. And part of this literature has focused on the consumer really being the core value creator and the service provider more as a value facilitator. Unfortunately, despite a number of studies over the last 10 years, most of them still remain conceptual in nature. And Vargo and Lush's recent paper in 2017, looking ahead over the next 10 years, they talked about the need for more empirical research. One such study that does provide some empirical evidence is the study by Yi and Gong, which looks at it in a financial services context. And they define customers' value co-creation behaviors to include information seeking, information sharing, and engaging in responsible financial and credit-related decisions. I think it's easy to see the potential transferability to the healthcare setting. And so in order to maximize this, we need to increase the access consumers have to informational resources beyond those the service provider initially has or brings to the table, and there needs to be that supportive environment for resource integration. Unfortunately, the shared decision-making literature shows that their efforts to engage both the patient and physician have mixed effectiveness. And it doesn't automatically, just because you have shared decision-making, lead to health behavior changes and better health outcomes. There needs to be further activation here in terms of engaging the patient and making behavior change.
Andy, a quick interruption. I don't think you clearly laid out enough what co-value means, which is the, could you go on that a little bit?
Sure. So the co-value creation or value co-creation requires that both the physician or service provider as well as the consumer are equally involved in the process. So they have a joint responsibility in terms of sharing information and knowledge. They have to both be active participants throughout the process. And a key part of that, as the bottom of the slide indicates, in order to maximize it, you have to, there's the whole resource integration process. So looking at the information that the service provider brings to the table, as well as the information that the consumer might bring through their external searches, and integrating that to make more informed decisions. And you know, value created or value co-creation really looks at the consumer's perceptions of how it increases their well-being, which certainly would relate to the healthcare setting. Now, in terms of the marketing literature, and really when we combine shared decision-making and the service-dominant logic, the literature suggests there's not enough information, especially given the rapid evolvement of digital technology, in terms of understanding how this information is impacting decision-making and consumer behaviors, especially given there's this information power shift that places greater control over a lot of the messaging in terms of other consumers. There's that user-generated or consumer-to-consumer content that you see in a number of consumer contexts. So the question becomes, how can service providers help facilitate this resource integration, especially that external information seeking? So with that, again, as a brief background compared to what I go into in the paper or at the proposal defense stage, I have 4 primary research questions. And each of these tie to at least one of the 5 models. The first research question looks at what are the differential effects of different shared decision-making elements on 2 types of consumers' digital information seeking. Provider-related, which focuses on digital information sources where the provider is going to have greater control over the messaging, such as the health provider's website, as well as the online or e-health records that consumers have access to through their provider. And secondly, external digital information seeking, where again, the control is going to be, the health provider is going to have less control and would include things such as social media, blogs, online health communities, forums, and so forth. Second, Model 2 looks at what are the antecedents to motivating consumers' external digital information seeking. Again, the resource integration literature within the service-dominant logic highlights the need to bring more to the table than just the informational inputs that the service provider brings to the table. The third and fourth questions really look at what's the added value of consumers' digital information seeking. First, in terms of the consequences on health behaviors, and then secondly, in terms of overall health. And that's where my health value co-creation framework comes into play. So broadly speaking, a collaborative orientation between the physician and patient is important to establishing value co-creation. There's also value co-creation in terms of the value assessments of using digital health information. So the 2 parties need to equally share in terms of their perceptions of credibility and digital health usefulness. And the physician can help facilitate that through the physician's digital influence. Combined, this will lead to greater digital health information seeking of both types, and ultimately result in increases in health behavior changes and other positive health outcomes. So focusing on what I did as part of my study. The methods in terms of data collection, I used a door-to-door survey of health consumers, and this study included the questions of interest that I'm looking at, in addition to other items related to consumers' health and wellness. And so my items were appended to an annual wellness study for a healthcare provider. Now this healthcare provider's service area covers approximately a population of around 70,000 people. And in order to get a sample that was highly representative of their service area, I used a stratified random sampling process to select the census blocks in which households would be visited for the survey process. To reduce non-response bias, pre-notification occurred, as well as using multiple visits to capture those that were not home on the first visit, including if after 2 visits they were not home, leaving a self-addressed stamped envelope and allowing them to mail in the survey. Now, because my study focuses on the physician's influence, especially in terms of establishing the shared decision-making orientation, as well as that physician's digital influence, they needed to have a primary care provider. So after excluding those respondents that did not indicate having a primary care provider, I end up with a sample of 310. And you can see some of the demographic characteristics of this sample. Now, to check for non-response bias, I used archival analysis to compare this study's results to the prior years. The results are very similar in terms of the demographics. I also conducted wave analysis to see if those that responded later on, including those that mailed it in, if their responses were different from the earlier responses. And looking at the constructs of interest, there were no significant differences there. And in terms of demographics, there were no significant differences at the 0.05 level. However, in terms of education, it was close to being significant and was suggestive that upon visiting the home, the lower educated people were more willing to, or more likely to respond at that point as opposed to later points in time. Oops. So looking at the measures, starting with those collaborative orientation measures. So the physician shared decision-making orientation looks at the consumer's perceptions of their health provider, empowering them and engaging them in the shared decision-making process. Health accountability looks at the consumer's sense of responsibility for taking active involvement in their healthcare decisions. The valuation constructs.
Andy, could you go back to the previous slide?
Yep.
Were there, you have those sources with that, their scale, or did you adapt their scale?
So the scales are, for all of my measures, are adapted more specifically to preventative healthcare and health and wellness setting. The shared decision-making orientation literature tends to focus more on a clinical decision-making process. So yes, my scales are taking their questions and adapting them to broader changes to health and wellness. Similarly, I adapted the measures for physicians' digital influence from the social influence construct of the UW literature, which looks at the physician's role in terms of supporting and feeling that it's important for the consumer to utilize online and digital health information. Digital credibility looks at the consumer's perceptions of the trustworthiness and reliability of using online digital health information in comparison to other sources. And then the digital usefulness, again, is adapted from the UW literature and looks at the perceived value of using online and digital health information to improve their health and wellness. I alluded to these 2 different types of digital health information seeking. So based on a review of the literature and I identified a number of different items here, and the scale points in terms of the frequency of using are again from the UW literature, specifically Barrero et al. 2014. And I look at 2 types of provider-related digital information seeking and then 4 types of external digital information seeking. And then in terms of those co-created outcomes, first of all, there's health behavior changes. I use a composite index following the instructions of Ballin and Baldry 2011 in terms of using a composite index for structural equation modeling. And these are 5 different changes that consumers could engage in related to their diet and exercise. And then finally, overall health looks at the individual's ratings of their overall physical health. And again, Vargo et al. 2008 identified that value creation is best defined from the consumer's perspective, and especially focusing on his or her sense of improvements to their well-being. I should also add here that the healthcare literature has demonstrated that these perceptual measures, in some cases, are actually better predictors of health outcomes than more objective measures like BMI.
I have a quick question on that, Andy. So is that a single item scale, and does the literature use a single item scale for perceptions of wellness?
Yes, so this is a single item scale. I also had analyzed it using a two-item scale, looking at their overall perceptions of their emotional and mental health, as well as their physical health. Most of the stuff still worked with the two-item scale, but one of the models, specifically Model 5, only works with it being a single item scale. And there is literature in the healthcare domain that does utilize a single item measure. So in terms of validating these scales, one of the first things I did was conduct a confirmatory factor analysis. And the measurement model fit scores are shown in the notes there at the bottom. Again, the goodness fit index, adjusted goodness fit index, CFI, NFI, those are all exceeding the 0.9 cutoff values. And in fact, two of them exceed the higher value of 0.95 suggested in the literature. Additionally, the RMSEA is below the 0.08 cutoff. I also looked at the scale reliability and validity. The Cronbach alpha scores there are all above 0.7, in fact, all above 0.750. And the average variance extracted is all above the suggested cutoff of 0.5, and in fact, the lowest is 0.617. Additionally, I checked for common method bias to see if this is a concern. I used two different procedures following the recommendations of Podsikoff et al. First of all, calculating Harman single factors, so having all of the items loading on a single construct. And this explained less than 29% of the variance, 28.7% to be exact. And then I also used a common latent factor in the CFA, or in the measurement model. And this allows those individual items to load on each of those different constructs while also loading on a single common factor. I looked at the common variance as well as the changes in the standardized regression weights. And again, here it indicated that common method bias did not appear to be an issue and therefore did not need to be controlled for. I sense a question? No, okay. All right, so again, I'm not going to cover in detail the results of models 1 and 2. However, just in case you were here the first time and you're like, well, what happened to them? Again, model 1 had some interesting results and looked at a multivariate regression to show some differential effects. And 5 of the 6 factors actually show differential effects. But again, they're built into my later models, so I'm not going to spend as much time on the results today. The second question in my research looked at the antecedents to digital health information seeking. In reality, this model is embedded in Model 3, which I'm going to talk about in more detail right now. So I'm really covering Model 2 and 3's results together. So what did Model 3 look at? Well, first of all, the greater the collaborative orientation, the more likely you are to buy into and make health behavior changes. So those two items will positively lead to more health behavior changes. Health behavior change is a high involvement situation, and research shows that in these settings, consumers tend to engage in more information search, and as they do, they gain extra motivation in terms of making health behavior changes, as well as gain decisional support to making those health behavior changes. So it's expected that both types of digital health information seeking will enhance the impact of health behavior changes beyond that shared decision-making environment. Additionally, that collaborative orientation will lead to both types. As you are more engaged in the process and the physician is involving you, you're more likely to seek out information so that you can share it with the physician and get their input to make a more informed decision process. Physician-shared decision-making orientation is also expected to directly impact or enhance your sense of responsibility for your health. And together, these items will lead to the physician playing more of a gatekeeping and value facilitating role in terms of how you form your perceptions of the credibility and usefulness of digital health information. So again, the physician, by recommending specific resources, either with explicit endorsements or even implied endorsements by taking the information the consumer provides, will lend greater credibility to digital health information, and together this will make the consumer view the information as more relevant and useful in their health situation and decision-making contexts, ultimately leading these three factors to directly impact provider-related and external digital. But there's also the indirect paths from physicians' digital influence through digital credibility and through digital health usefulness. Finally, although there's limited empirical evidence of this, there's suggested to be an information flow that's going to occur. Patients tend to turn to their health providers and physicians and view them as an important source of information. So they're likely to go to the health provider's website first. Some studies that look at content analysis of health providers' websites also suggest they're increasingly linking out to external resources. So, Model 2 would have had everything here except for the 4 paths to health behavior changes. Model 3 is adding this in, and importantly, the results showed that all the prior relationships held true when health behavior changes is added. So let's look at the results, and there's some really, I think, interesting results here that will make my study of interest not only to researchers but also to practitioners. So first of all, in terms of those direct paths, 3 of the 4 direct paths indicate positive significant relationships to health behavior changes. So the physician-shared decision-making orientation and health accountability both lead you to take greater or make more health behavior changes to your diet and exercise. Looking at digital information seeking, the more you engaged in provider-related digital information seeking did not have a significant direct effect on making health behavior changes. However, the more you engage in external information search would suggest that you've become further activated and are therefore more likely to make those changes. And you can see a positive significant relationship from external digital to health behavior changes. But provider-related digital does have an indirect influence on health behavior change to the extent that there's value co-creation in terms of motivating additional external digital information seeking. What if we go back further? Well, what leads to that digital information seeking? Again, here we find a second interesting results. Although physician-shared decision-making orientation positively impacts provider-related digital information seeking, and the more sense of responsibility or accountability you feel for your health, the more likely you are to seek out both types. There was actually a negative direct effect from physician-shared decision-making orientation to external digital information seeking. Well, that's interesting. That's opposite of what was expected. So what might explain this? Well, in part, it might be reflective of the tradition, what's known as the traditional paternalistic view of the healthcare delivery model, in which even though there's shared decision-making, the health provider feels more comfortable in terms of sharing provider-approved and evidence-based information and therefore kind of limits or reduces the amount of external digital information seeking. Another possible explanation might be that as you're engaged in more shared decision-making with your physician, you actually place greater trust in the information that they're sharing during the service encounter and therefore feel less of a need to go out and seek additional information. Clearly, I think this is an area where, from a future research standpoint, there's some interesting opportunities to look at, well, what else might be moderating this influence. I also looked at bootstrapped results. So although there's a negative direct effect, the net total effect is actually positive, and it's through the indirect influence that physician-shared decision-making orientation has on external digital by increasing your sense of accountability, together increasing the value facilitating role of the physician in terms of influencing your credibility and usefulness perceptions. So both the physician-shared decision-making orientation and health accountability lead to greater digital influence that the physician plays. This has a strong effect in terms of enhancing your perceptions of digital health information's credibility, and together we see that impacting digital health usefulness. So again, there's value co-creation in terms of creating a collaborative orientation. There's value co-creation occurring in terms of forming the consumer's value assessments. And there's value co-creation in terms of the actual motivating the actual external digital information seeking. Now, additionally, I looked at those direct paths. And I know it gets a little bit messy here on the slide in terms of all of the different paths. And what we see here are the direct effects from digital health usefulness to provider-related is 0.228, and it's 0.467 to external digital. So digital health usefulness does lead to more of both types. But the direct effects from physicians' digital influence and digital credibility to the two types are not significant. In other words, digital health usefulness fully mediates the impact of the physician's digital influence and digital credibility in terms of leading to greater digital health information seeking. Really another interesting finding here. And as I showed earlier, that path from provider-related digital to external digital, which again, in turn, motivates further health behavior changes. So if I get rid of the significant paths, here's the reduced model that I end up with. And again, there's value co-creation at multiple stages in terms of leading to greater health behavior change. And I think that's one of the biggest contributions in terms of my study, is looking at how value co-creation exists and originates out of that shared decision-making environment, and how it can be enhanced by engaging consumers in specifically external digital information seeking. So looking at Model 4. Model 4 was tied to my fourth research question, which looked at the impact that digital information seeking of both types has on overall health. So I am using a parsimonious model here to focus on, once you engage in digital health information seeking, what impact does this have? And here, as you make more changes to your diet and exercise, it's likely that you're going to feel better overall, have higher perceptions of your overall health. And as you engage in more information search, again, you have that increased motivation to engage in those healthy behaviors, and is likely to provide informational support and help you have a better understanding of your overall health. And research has also shown that the lack of informational resources is associated with negative health outcomes. I used multiple steps in terms of analyzing this parsimonious model. Again, the first aspect was using structural equation modeling. And here we see that there is actually a sequential process. That it's only through this value is only created through this concept of value in use. You actually have to put the information to use. You can't just search for more information. If you don't make the behavior changes, it's not going to have the added effect in terms of co-creating your overall health. Additionally, it's only when provider-related digital health information helps motivate and engage you and activates you to seek out additional information that this process occurs. Now, in order to not just take the initial SEM results, I also ran composite-based SEM. Again, the paths all held. Similarly, I used the process macro in SPSS, which proved a serial mediation relationship exists, and therefore provider-related digital information seeking has an indirect effect on overall health through motivating more external digital information seeking and on through the process. So I used multiple analytical techniques to confirm the findings here. Finally, Model 5. This was actually not in my original proposal, but it was something that I added as part of the process in terms of conversations with my committee members. Well, does Model 4 really hold true when you add back in that collaborative orientation? So this investigates, again, another parsimonious piece of my overall framework by adding back in that collaborative orientation of physician-shared decision-making orientation and health accountability. How does this lead to additional digital information seeking, and how does this impact health behavior changes and overall health? And essentially the key thing, without again getting lost in all the numbers here, all of the prior findings in terms of significant paths and their directions holds true. That the greater the collaborative orientation, the more you will ultimately engage in digital health information seeking. Again, we see that negative path from physician-shared decision-making orientation to external digital health use. But again, the more it creates accountability, the greater your provider-related digital health use and external. So even though there's still a negative direct effect from physician-shared decision-making orientation to external digital health, again, there was a net positive effect. And more importantly is really the part at the end of the diagram here that shows that sequential process that by further engaging consumers in digital information seeking, and particularly that external digital information seeking, do we see further activation beyond the shared decision-making environment to make health behavior change and lead to higher perceptions of overall health.
Andy, in Model 3, when you did the a bootstrap, you said the compositive effect was positive. When you took out the digital pieces to it, the credibility, et cetera, what was the net effect?
So yes, so looking at the bootstraps results, the net effect of physician-shared decision-making orientation on external digital health use is still, the net effect is positive. So although there's a negative direct path there, that negative 0.228, by motivating the consumer to become more responsible and accountable for their health, as well as by directly the direct path from physician-shared decision-making orientation to provider-related digital health use, and then on indirectly to motivating external, there's a net positive effect.
Now a question right out of the blue. Have you thought of what else you could add to your model to increase that net positive impact? Something you haven't used?
Well, I mentioned earlier that negative effect really represents an opportunity for additional research and digging into what might explain this. And I think one general area is looking at the relationship or different relational factors between the physician and the patient, including their level of trust placed in information shared by the provider. So I think that would certainly be interesting. In terms of, I guess, variables that I already have, it would be interesting to just add the physician's digital influence and look to see if that might further moderate, which I guess I do in Model 3.
So quick question on that, Andy. So have you looked at how these results change for different demographics, especially education?
Yes. So I included moderating influences as well as in Model 4, I controlled for the different demographics. And in terms of moderating influences in the structural equation model, using those different demographics, the overall model fit and looking at the chi-square difference test indicated that the overall models didn't change. However, when I looked at the critical ratio tests, there's certain pathways that do show some significant differences. And in terms of a couple off of the top of my head, I know in terms of gender, females, again, it was significant for both males and females, but females place greater importance in terms of, or it had a stronger effect on their digital information seeking from physician-shared decision-making orientation to provider-related digital, as well as if I went back to the prior model in terms of the physician's digital influence. So it's kind of suggested that the physician can have an even stronger impact with females patients in terms of motivating this external digital, or both provider-related and external digital information seeking. In terms of education and income, and I have a slide in my appendix of slides that I can bring up that more specifically talks to some of the other moderating influences. Overall, there were very few changes in terms of the pathways. So as a way of wrapping up and kind of summarizing some of the key implications, again, the value co-creation literature has been primarily theoretical or conceptual in nature to this point. And so one of the major contributions my study provides is that it shows that value co-creation exists and at multiple points in this shared decision-making environment. If you think about the ultimate goal of consumer wellness initiatives and really all encounters that patients have with physicians, you want to create more engaged health consumers and motivate them to make health behavior changes and in turn enhance their overall health. My study demonstrates that shared decision-making environment is a critical component of this value co-creation and enhances the value co-created to behavioral change decisions as well as to overall health. First of all, again, the physician shared decision-making orientation, the stronger that is, the more it enhances patient engagement and patient involvement in their decision-making. Together, these enhance or lead to greater health behavior changes and in turn enhance overall health. So there's value co-created at that establishing the shared decision-making environment stage. There's value co-created in terms of the overall behavior changes and overall health. But that's not the only thing. My study also shows value co-creation exists in terms of, or really is enhanced by creating a supportive environment for valuing and incorporating different digital health informational inputs, and in particular, those external digital health information inputs. So what about implications in terms of motivating that? How do we motivate that external resource integration? Well, again, it requires, first of all, to have a shared collaborative orientation, so both parties need to feel it's important and value participating in a shared decision-making process. Secondly, both need to hold similar value assessments in terms of digital health information's usefulness and credibility. Without these prerequisite conditions, consumers' digital health information seeking will be reduced. And as I allude to in the title of my study, the physician plays a key value facilitating role here. So they help co-create value by forming or influencing the consumer's value assessments of the information being credible and relevant. As consumers' perceptions of usefulness are increased, this will lead them to seek out and utilize and integrate both types in their decision-making process. And finally, and if you want to think about this from a practical standpoint, health marketers and health providers need to think about how their digital presence is set up in terms of motivating and directing consumers specifically to resources that are credible and relevant to the consumers and therefore useful to the consumer's health situations. So looking at how they can help facilitate that and make it easier for consumers not just to access it, but to assess the relevance and credibility. There need to be some decisional support tools here. Finally, as another contribution to the service dominant logic literature, some of the early work talks about the value creation role of the service provider only being during that service encounter. Think about how often you may go see your physician. Perhaps if you're healthy, you don't even go every year. Perhaps you're only going for a single checkup and there's a 10, 15-minute time period that you're interacting. If we took that restrictive view that that's the only way the physician can enhance value, it would be very limited. This study shows that the physician's value co-creation role can be extended beyond that service encounter by facilitating and encouraging consumers' digital health information seeking, and in particular, motivating them to seek out that external information. Now, I'm really excited about my results, and I know in talking to my committee, there's excitement in terms of those surprising findings and getting this published. But like any study, there are some limitations. Because the primary service area of the healthcare provider is, I don't want to call it really a rural setting, but it's certainly not an urbanly, ethnically diverse setting like a Chicago, New York, et cetera. So one of the questions is always going to be, is this going to be generalizable to a more diverse population? But again, I think my study offers some initial exploration of this value co-creation process. My study does focus on a limited set of diet and exercise behaviors. What impact would digital information seeking have on either reducing other negative behaviors like smoking, alcohol use, et cetera? Unfortunately, again, because my survey items were appended to a consumer wellness study, I was limited in terms of the number of behaviors I could ask about, but certainly an area that would reflect need for additional research. And it does rely on self-report measures in terms of consumers' information seeking and behavior changes. I think one of the interesting things is as consumers adopt more digital technologies and there's advances in telehealth in terms of remote monitoring, how are patients going to share data or share data with their physician in terms of the health apps or Fitbits and fitness trackers? There might be opportunities for future research to actually look at their engagement and use of those types of digital health tools. So some other areas, and some of this I touched on at various points, but I think that my study points again to that relationship between the physician-shared decision-making orientation and external digital information seeking. It's something that warrants further investigation. Why was there a negative direct effect? This is because digital health information, while we certainly had the internet for a while, the new technologies like health fitness apps, fitness trackers, and things along those lines would suggest this area is constantly evolving, and I would imagine that physicians' perceptions will hopefully evolve too over time in terms of the usefulness of this information, and perhaps that will reduce some of that negative direct effect. So there's certainly some relationship factors that I would like to dig into further and that I think future research is needed on. My study also showed the importance of the physician in terms of motivating or contributing to consumers having higher assessments of the credibility and usefulness of information. So I think it would be interesting for research to dig into what motivates the physician. So it would be taking it from a different perspective. And then also, while I look at provider-related and external digital health information, I would venture to guess that there's a greater continuum. And one thing that would support this, in May of this year, for the first time, the digital health marketers created a first ranking of the top 500 hospitals in terms of their digital presence. And they looked at a number of different factors that I think, again, would suggest that there's additional digital health resources that are worth looking into as telehealth expands and patients are more likely to see their doctor online, or maybe not even their primary care provider, but they're going online for some type of video chat or e-visit. So I think that warrants future investigation as well. So I know there's been some questions already, but I would now like to open the floor for additional questions and or comments.
Well, when you did your defense of your proposals, there's many more people clapping, so they're still happy in the background there. When we started today, I didn't fully introduce your committee, and you didn't introduce your committee either. But on the other end, from afar, is Dr. George Milne. He's the director of the PhD program at UMass. George, there you go. He's one of the leading experts in public policy, and so we very much appreciate your contribution. We have Pavan Chinamani, who is a reader, and then we have myself. George has been patiently hearing our questions, and we've asked them as we've gone through it because you had those slides on the screen. So George, if you want to ask your questions first, because you're silently behaving yourself back there, so we'll let you start off, George.
Well, first of all, I'd like to congratulate Andy on a fantastic presentation, and the document is one of the best I've seen in a long, long time, so very well done. One of the disadvantages of being in the background is that some of you guys stole my questions, but the answers were great. My questions can be a little bit more looking at this problem you have with Model 3, which I think is fascinating, that the influence of the physician on external health is negative. Do you think there's something to do with the type of external information that may be influencing that negative reaction? Is it other websites, or do you think it has something to do with the physical information devices that people might be looking toward?
Well, it certainly could relate to that. There is literature, especially in the healthcare and shared decision-making perspective, that suggests that physicians can actually demotivate or demotivate patients by dismissing informational inputs that they share. So there certainly are a variety of social media sites, blogs, and so forth. So that specific type, one of the things I didn't do is take those individual items that are part of my scale and look at how the physician shared decision-making orientation might relate to them individually. I was looking at it as a collective scale. So there might be an interesting, I guess, study to look at how that might be different based on those individual items or individual types of external information.
Okay, good. Your theoretical basis for your dissertation, service dominant logic, you mentioned at the onset that there hasn't been a lot of empirical work. And I would say that, your dissertation is starting to contribute toward that, adding to, the financial study that you reported earlier. As you continue to push this area, do you think that you're going to be able to identify any boundary conditions to this theory? Would any of your work suggest where the theory might hold and where the theory might not hold?
Well, I think, given the importance and that critical element of establishing a shared decision-making aspect, it would have to be in service contexts in which, maybe the patient, or I shouldn't necessarily say patient, but really the consumer might be initially at a knowledge disadvantage. So, I wonder how this information asymmetry, given, clearly in healthcare, the service provider, the healthcare professional tends to be at a knowledge advantage compared to consumers. What if we looked at this in other service settings where maybe there's not as much of a knowledge difference. That might be one aspect. And I think there's certainly looking at how this might play into different retail settings. But I guess I haven't totally thought through what other boundary conditions. But I think that it's certainly an area that is very interesting. And the fact that there is little empirical evidence suggests that there's a need for investigating those different boundary conditions.
I think Pavan asked a question about the different demographic differences that might exist within your within the patients. One other construct might be this notion of empowerment, consumer empowerment. Could you talk about how that might explain some of the differences that you see in the model? That some consumers may be more empowered to take action than others, or be more with information?
Well, I think there certainly would be, and I guess thinking about that question as well as your prior one, looking at consumers' health literacy, especially their digital health literacy, how capable are they of processing the information. That would certainly impact how empowered they feel. I think that there's certain consumers that maybe because of chronic conditions they have, you would think that they may feel that they, even if they are making changes, it's harder for them to actually see positive results of those changes. Although, in terms of looking at my study with the presence of chronic conditions, I just asked if they had one in their household. I didn't narrow it down to what was the chronic condition. So maybe there's differences based on those specific aspects. Or at least I didn't investigate that, I should say, in my study. I do have additional data that could look at those elements and start to explore those. But I didn't feel that was the focus of the study at this point in time.
No, I bet it may be, as you said, something for the future. All right, I don't want to dominate all the time here, but I think my last question would be that, you had a very unique data set, and I think you found some fantastic results. And if you had the opportunity to do a new study, what would be your ideal data set that you had, let's say, a good chunk of money, so financials were not a constraint, and if you're going to design a new study, what type of data would be ideal for you?
Well, assuming that consumers would also be willing to fill out lengthier studies or surveys, I think it would be interesting to add those additional aspects of or additional elements of the digital resource continuum and look at other telehealth issues. I think it's important to see how does this generalize or carry over to a more diverse population. So, if I had more money and I could get the funding, it would be interesting to look at it on a national basis. Perhaps if I'm even dreaming big, maybe you look at it in terms of whether there's cultural differences and look at it across countries and so forth. But that might require a really large budget to get to that point. So, I think that expanding the population to make sure it does include more of a diverse respondent profile would be important.
Good, thank you.
So Andy, another question on this. This result is very interesting, right? Shared decision making has a negative direct effect on external digital information seeking behaviors, but a positive effect on provider related digital information seeking, right? Now, did you consider, the valuation of digital health information input? Did you delineate how customers value provider related digital information differently from external digital information, and how that valuation is being affected by shared decision making? Would including that make any difference?
So in terms of the multivariate results, it does show some differential effects between how strongly it impacts the two different types. So those individual valuation constructs of the physician's digital influence and digital credibility and digital health usefulness. Only digital credibility didn't show a difference between the two. However, physician's digital influence and digital health usefulness did show stronger effects on one or the other. And so I think that is something that the results of my first model offer some interesting findings there. The research would suggest that because physicians typically have been more skeptical, they would have been more likely that even when they supported information, they direct people more to provider related. But the physician's digital influence actually had a stronger association with external digital from my multivariate results, which I thought was, again, another surprising finding compared to what the literature had suggested.
So your again, I don't recall the actual scale for that. So the digital health usefulness was about digital health information in general, and it did not
Correct.
separate their perceptions of
I understand. No, the physician's digital influence, digital credibility, and digital health usefulness in terms of how the questions were framed was related to their perceptions of using online and digital health information in general. It did not parse out what do you view in terms of the credibility of provider-related versus external, or even to George's earlier question, to the individual different types of external or types of websites, blogs, social media. So again, I guess that would be another area for future study to help set up and look at additional moderating influences here.
Thank you, Pavan. Thank you, George. Andy, what's the single biggest mistake you made during your dissertation?
Single biggest mistake. Is this a trick question? I think one of the things, maybe I'll talk about one of my frustrating parts, was running and rerunning models over and over again. It takes a lot of work in terms of the structural equation modeling to test alternative models to make sure that the model that you're presenting is the most valid, and I think just the amount of time that took, I think I underestimated how much time the complexity of all these models was going to take in terms of doing the analysis. I don't know if I'd call that a mistake, but I know it certainly lengthened the process.
Well, I think we can open it up to if anybody else has any other questions before we shut this down.
Can you go back to Model 5?
Yeah.
Excellent presentation, very interesting, and your unexpected findings as well. I think I was one of the ones with the results that expressed some skepticism that you could even get to this, so here you are, and I think it's a nice addition.
And I did check for statistical power.
I'm not going there,
Okay.
I promise. You've got statistical significance. Address the issue that by traditional social science standards, some of these are not high in magnitude. Why does it matter that you've got a 0.112 from health behavior change to overall health? Why? Speak practically, even though that may not look large, why that matters.
So from a practical standpoint, again, improving consumers' health and wellness and motivating health behavior changes has a number of important implications. I mean, obviously, if you're not making, whether we're talking about reactive health behavior changes because your health situation isn't great, but even just from a preventative healthcare standpoint, it's very important to make health behavior changes and maintain healthy lifestyles in order to avoid negative health outcomes, mortality, et cetera. And additionally, this has a major, I guess, policy impact in terms of the costs of the healthcare system. And this need to transform the service ecosystem or the health service delivery model to make sure that physicians really are fully activating patients to improve their health. And as I said earlier, if the end goal is to increase involvement in making health behavior changes and overall health, this does show, or my results show, that there is a process, with this value co-creation process, that can enhance consumers' overall health outcomes. So I guess my answer in terms of, it's a small effect would be that it's still making positive inroads in terms of an area that weigh down the healthcare system because of increased costs associated with having poor health behaviors or a poor health status.
Right.
And you probably should have brought back in, you only chose a few health behavior changes, and so that's
Right.
the bigger issue.
No, I
Great question,
get
by the
that.
way.
I don't mean for the dissertation, so please relax on that. But you might think about trying to show some type of cost-benefit piece here. For this type of change, for every positive change in people doing these things, this is the expected gain, net gain to the system of people eating better, whatever those things are, because you can get that data.
Be a good hook
Yeah.
in the intro
Right.
of a top-tier journal paper.
Yeah.
What's so good about your question, John, is that you didn't parse out if a person had extremely high cholesterol and they made a behavioral change, you'd see a much bigger effect. Because there are some healthier people in here as well.
Right.
You haven't differentiated sickness level. So obviously, someone who has extremely high blood pressure or is very obese or very high cholesterol, they're making changes, you would see a bigger effect. So I think that's a great question. I think that's, I don't know if we have that in the data set or not.
And this is in addition to the actual medical intervention that affects the health. So if you're able to show any improvements just because of these behavioral
Right.
changes, that in itself is of great value, right?
Absolutely.
Right. Good. That was it. Last thing, real quickly, you're speaking to your undergraduates this fall, your Dr. Dahl. What's one highlight you want to tell them from your study? Just pick one.
I think importantly, from a marketing perspective, it's important for those that are involved in creating their company's online or digital presence, as well as for the service providers to realize that consumers are using more than just provider-approved information sources. So it's increasingly important to look at how, as marketers and those involved in the service design process or management process, can make sure that those consumer needs are fully being incorporated. I think, especially within the domain of marketing and my focus on digital marketing and teaching that I think that's a key lesson that I would incorporate from my particular study.
Good. Thank you. That's all I have. Anyone else? We done then? You want to wrap it up?
We're done, George. I'll call your cell phone and we'll see if he passed the mustard here. And thanks for the audience. And Andy, you did a wonderful job. This is good stuff.
Thank you guys very much, and thank you to my committee.
I think it was truly one of the best dissertation defense presentations I have attended. So very good job, Andy. Congratulations.
Thank you.